So, we'll study together the slides of the first 3 laboratory exercises of Pathology 1, and I'll just show you some microscopic findings, and you'll understand them, and that's what you will have to show me on Monday, okay? On our midterm exam, which is optional. It's not compulsory. So, our first slide has to do with the myocardial infarction. So, what do we see here? Look, we have all these cells. Let's try and see all over here. Okay. So, what's wrong with these cells? You see, they are fragmented because this is a result of acute ischemia. This is coagulative necrosis. So, these are necrotic cells, and what we see is some sort of the contour of the pre-existing viable cells. And what are the signs of necrosis? All striation that muscles have is no longer present. And most importantly, what do these cells lack? What do they lack? They have no nuclei, so they are non-viable cells. So this is an area of acute, hyperacute myocardial infarction, where we see fragmented myocardial fibers without any striation and without any nuclei, which is compatible with necrosis. However, nearby, we see that there are some other lesions. Here we have a similar image. You see how fragmented the cells are. And let's have a look here. What's an additional finding that is apparent here and that was not apparent in the previous image? What else do you see here? This demonstration is being taped, so you can have a look at it during the weekend from my YouTube channel, all right? So, what additional do you see here? Yes, please. Yes, please. Yes, there are some viable cells, which, however, are not myocardial fibers, okay? So, let's have a look at these cells. Now, how would you judge the configuration of their nuclei? What would you say that their nuclei look like? What is it? What do you think? Yes, please. Yes, they're lobulated. So, and this is consistent with which sort of inflammatory cell that has a lobulated nuclei? Then? Just a moment, just a moment. Who is talking here? What are we doing here? Do you want to tell you what we are doing here? This is an option. Your presence is optional. That means anybody who is here wants to be here. All right? There is no need. There's nothing obligatory to do. We don't have you in a prison of some sort. You are here because you want to be here. So don't talk to each other. You talk to me. I'll ask questions and you'll answer. I'm not a guard, okay? I try to be a teacher. It's not easy, I know. I know it's not easy at all. But I keep on trying. It's a matter of neurosis, probably. So what were we saying? Which cells have the lobulated? The neutrophils. So these cells come there about after 12 hours from the onset of the infarction. So we just see the neutrophils. These are the first cells which are motivated by the acute inflammatory process. And here, which is the stimulus for inflammation? Necrosis. Because inflammation is activated with any sort of damage. It could be a microbe. It could be an excess heat exposure of the tissues. Here is the necrosis. So necrosis causes inflammation, and after 12 hours, we see the lobulated nuclei of neutrophils. So what do I say? I'll give you the myocardial infarction slide, and I'll tell you, show me the neutrophils. That's all. By the way, you have all the slides at your disposition from the documents. If you open the documents in your e-class in the portfolio, you'll find all the links for all exercise, for all laboratory exercise of Pathology 1. So, is that clear? So what do we see here? We see non-viable, necrotic, fragmented myocardial fibers and the accumulation of cells of acute inflammations, neutrophils. That's simple. Yes, please.
Can you please show us again the fragmented fibers?
Yes, here they are. You see they are densely eosinophilic without any striation, despite the fact that there are muscle cells and some sort of striation should be observable, but it isn't. Why? Because they are necrotic. And in other areas, fragmentation is more apparent, like here. Let me show you. You see how fragmented they are? Because they are dead. They are necrotic. Bless you. Okay? So, that was the area of acute infarction. And there is another feature in the slide. What tissue is this here? Here we have no fibers, no muscular fibers. We have another sort of tissue. Can you identify these cells? I'm sure you know them from histology. Which cells are they? These cells? Yep. Fibroblasts. So this is a fibroblastic reaction. That means that we had the necrosis, the accumulation of neutrophils. We have the formation of granulation tissue, and gradually we have scar formation. So what we see here is an accumulation of fibroblasts, and if we see any inflammatory cells here, they would be like this. What is this inflammatory cells? Have a look. This one, for example, this. They're mononuclear cells. So, what is this here? What does this mean for the duration of the inflammatory process? Yes, please.
Something chronic.
Chronic, yes, that's right. This is chronic. So this is chronic inflammation leading to scar formation. That means that the patient had suffered from myocardial infarcts in the past. However, he had survived that infarction. Unfortunately, on the background of the old infarct, a new infarct was set, and this proved fatal. That's why we have the autopsy specimen of the heart of the patient. Yes, please.
The cells that you showed in the chronic inflammatory, they are lymphocytes? But
mononuclear cells. Mononuclear cells. Yes. Mainly lymphocytes. Mainly lymphocytes. Because macrophages are also cells of the acute phase of the inflammation.
You don't care about the time?
No, but they are too little. They are too few. Mainly lymphocytes. Yes, let's have a look and try to discriminate them from the fibroblasts. These are the fibroblasts. You see, they are spindle cells. Fibroblasts are spindle cells. And this is a mononuclear cell, this one. You see? So this is the scar. So if you have this slide, the whole exam will last about 5 seconds, 6 seconds, 7 seconds. It has nothing to do with theory. I'm not interested in theory. I'm interested in identifying something. I'll say, what is this? This is scar tissue. This is the old infarct, and what do we see? We see fibroblasts. Show me a fibroblast, you show the fibroblast, and you get 2+. That's simple. No theory. I mean, I'm allergic to studying. I don't like that. Studying things that you don't understand for your job. I do not like that. I'm a bit imbalanced, some sort. Yeah, there's some sort of thing, I know. But that's the way, that's my way. I don't know what can I do. So that's the first slide, okay? I have another idea. If we finish the slides soon, I can have the exam now. So there won't be too many. So just a moment. So that. So here is another. Sorry. Here is another slide of myocardial infarction. Again, what do we see here? Fragmented myocardial fibers, and this is acute infarction because we see many neutrophils. It's the same as previously. This is again the scar, old infarction, and hyperacute infarction where the neutrophils have not yet reached the area would be something like that here. Only fragmented myocardial fibers. Next, we have liver tissue. Okay. Now, this is a part of the liver. Okay, so we'll see the hepatocytes and the sinusoids around them. Okay. Now, we are looking for inflammatory cells. Let's have a look and find the inflammatory cells here, because this is liquefactive necrosis, meaning that we have to find, here we are. So, now, all these cells, please identify them. It's easy. Have a look at their nuclei. What cells are they? Neutrophils, yes. So this means acute inflammation. If we have a microscopic accumulation of neutrophils, this is called a microabscess. It's not an abscess that means a cyst filled with pus. This is a clinical term. On histology, if we find many neutrophils together, we describe this as a microabscess. And so, how can this come and be formed in the liver? Perhaps he has a trauma, and we have microbes from the skin entering the liver, if somebody is stabbed, for example. In another way, we have appendicitis, and we have all the inflammatory exudates from the fat tissue where there are some venules there, and the inflammatory exudates enters the venules and through the portal vein goes to the liver, and this is hematogenous spread. And the other is if there is a stone in the biliary tract, there is a stone, so there is stasis. When we have stasis in a part of the body, microbes develop. So we have an ascending cholangitis. That means that the bile cannot be secreted to the duodenum, so there is stasis due to either a stone in the bile duct or a cancer from the head of the pancreas struggling the bile duct. So there is bile stasis, cholestasis. So we have an ascending infection. That's why we have the neutrophils in the liver. So what will you show me here? You look for the neutrophils. Here they are. And all this area where we have a microabscess, an accumulation of neutrophils, is called liquefactive necrosis. So that's all. And perhaps we would like to look for a bile duct and see if it is filled with neutrophils. Here we have another area of liquefactive necrosis. Let's have a look here. So, what structure is this? Who can tell me? What structure is this? It has a lumen, you see? The empty. A lumen, and we have a well-developed lining looking at the lumen. So what is this? Yes? It's a glandular structure. A glandular structure in the liver is a bile duct. Yes. So if we had many cells there, we could presume that it was an ascending cholangitis. However, in this specific bile duct, there are some inflammatory cells here. Can you identify them based on the nuclei? Can you identify them? Which inflammatory cells are these here? Which are they? You'll have the look at the shape of the nucleus. If the shape of the nucleus is round, you say mononuclear, mainly lymphocytes. If it is lobulated, you'll say either neutrophils or eosinophils. Eosinophils are red. Their cytoplasm is red. In neutrophils, it isn't. So which cells are here? Have a look at the nucleus contour. If it is round, they are mononuclear cells. What do you think they are here? Their lymphocytes get +2, +2, yeah, that's all. You have 3, plus you get +3, you guess. So that's the whole. No. You have to study. You have to study more. No, it's not enough. You have to study the textbooks more. Yes. To learn. Yes. Okay. So that's all with this. Yes, please.
Can you show, I'm not sure if it's visible, but can you show us one Kupfer cell?
Oh yes, of course. Let me go where we have the trabeculae of the hepatocytes and look at the sinusoids. That's where Kupfer cells lie. However, since we have inflammation here, there is some sort of disfiguration in the architecture, and it won't be easy, but let's try and see a place where we have the sinusoids. Oh yes, here we are. So these are the trabeculae of the hepatocytes. So if you see a nucleus looking at the sinusoids, this could be a Kupfer cell. That's how we look at them. I think this might be a nucleus of a hepatocyte. This perhaps here. Something like that. Because they're somehow flattened, They're flattened cells. Yes. I won't ask you about the Kupfer cells. I'll ask you about the neutrophils and the microabscesses. And if they are connected with bile ducts, or are they throughout the liver parenchyma? That's all. Is it simple? Is it easy? Yes, it is. Is it a source of anxiety? No, of course not. It's just two things, to understand something practical. Okay? These are the microabscesses in the liver. And we discussed how they could be formed there. That's all. Next. Here we have a lymph node. So, what do you think? Which is the normal lymph node tissue, and what is the abnormal? So, what do lymphocytes look like? They are dark cells. Why? Because they do not have enough cytoplasm. So, what you see here that is dark, some sort of purple, is the normal lymph node. What are these structures here? You see that there is no tissue here. You see all this? This is some sort of nuclear dust. All these fragments you see here, you see how little, how tiny they are? These are not whole nuclei. This is nuclear dust because the nuclei had broken, were fragmented. So it's a necrosis. However, if we have such a necrosis in the lymph node and you have a macroscopic view of the lymph node, it looks like white cheese. So this is called caseous necrosis. Okay? So this is caseous necrosis, and the main, not only, but the main cause of caseous necrosis, either in a lymph node or in any tissue, is which disease? Tuberculosis. So always perform a Gill-Nielsen stain to highlight the bacilli of tuberculosis, because many fungi can cause caseous necrosis. So you have to be sure that on the background of caseous necrosis you have tuberculosis. So you need at least a Gill-Nielsen histochemical stain, or you can get some tissue and send it, not so much for culture, because the Mycobacterium takes quite a long time to develop in the culture. You have PCR with the genome of the Mycobacterium of tuberculosis, and if it is positive, you can diagnose the disease and the patient gets the therapy, the respective therapy. So this is caseous necrosis, this is nuclear dust, okay? And of course, there are these areas of necrosis are not so well formed that like the ones that we see next. So I'm not sure that I can talk for immune granulomas here, because what is predominant is the necrosis and not the granulomas, the balls that we'll see in the next slides of inflammation. So if somebody is examined on this slide, what will he show? Where is the normal? Where is the normal lymph node, parenchyma? Here it is. This is the normal, okay? Where is necrosis? That's necrosis, okay? And with nuclear dust. And what is this necrosis? Caseous necrosis. So Jill-Nielsen histochemical stain is mandatory to diagnose tuberculosis. This is fat tissue, and this is another lymph node with some fat cells in it. That's all. Yes, please.
The bottom left lymph node.
Come here and show me. Come here.
Is it almost for the entire thing necrotic?
Here is necrosis, yes.
No, this one.
This is almost everywhere. Yes, it's widely necrotic. Yes. In such a case, what could happen? This might be an immunocompressed patient, and he would not have enough lymphocytes to produce the lymphokines and make the granulomas. That's why in immunocompressed patients, we just have the necrosis without the formation of granulomas, because in order that granulomas are formed, you need the immune system. So if the patient is immunosuppressed, he won't have the lymphocytes to produce the lymphokines that will tell the macrophage to be only secretory cells and have the epithelioid transformation and form the granulomas. So in that cases, you just have the hypersensitivity reaction, which is, in the present case, caseous necrosis. Right? Any questions? Is it clear? If you don't understand something, you raise your hand and tell me, I do not understand that, and I'll explain it. It's no problem if somebody does not understand something. That's normal. If somebody understands everything, is not normal. Okay? Next. Here is another slide. Here we have the granulomas more nicely formed. You see the granulomas? So what might I ask? Now, have a look at these two. This is one granuloma, all right? Immune granuloma, and another granuloma, okay? So I'll ask which one has caseous necrosis and which one doesn't have caseous necrosis, because the presence of caseous necrosis is not mandatory for the diagnosis of tuberculosis. An early granuloma may not have caseous necrosis. So which one has caseous necrosis? Which one doesn't have caseous necrosis? That's the question. That's the difficult question. Remember how caseous necrosis looked like? It was some part that the tissue was of no shape. So can you show me? Yes, come please, sit here and show me, please. Okay. Which one, the right or the left?
The left.
Here is the left.
No.
What am I showing here?
The fragmented.
Yeah, okay. You gave +4, you gave. Yes, that's +4. No need to come to the last term exam. She has already got all the bonus. From the preparatory course, she got all the bonus. So, next slide. Here is another lymph node. Let's have a look. You see the immune granulomas. Here we have caseous necrosis. And is there something else for us to see in these granulomas? Have a look at this tissue. You see here in the fat tissue, there is some sort of epithelial tissue as well. Yes, please. Come here, please. Come and sit here. So, have a look at this granuloma. You see, these are only epithelioid histiocytes. Sit. Okay. Have a look at this one. You see this area here? Yes. It's some sort of, you see, it has no structure. Okay. Here we see the epithelioid histiocytes that form the immune granulomas. In this area, we do not see it. Okay. So this is casus necrosis. But sit here, don't go yet, don't go yet, your seat. Because I want you to show something else. This is the lymph node parenchyma. This is salivary gland tissue. Here we have some epithelial axini, salivary gland, and these are ducts. It's most probably either, how is this called? The submandibular. This is the parotid here, and this is submandibular probably because it's close to the cervical lymph node. So if you remove surgically a lymph node from the neck, you might get some parenchyma of the adjacent submandibular gland, salivary gland. So this is epithelial tissue, and there is an increased amount of fat cells. Let's have a look at this, at the granulomas. Show me the necrosis. Get the mouse and show me. Show me where the necrosis is.
Here.
Here it is. That's right. So this is a necrotic granuloma. And have a look here. There are some cells here that they are multinucleated. They have many nuclei. So they are giant cells. These are due to the coalescence of macrophage. And interestingly, they have a configuration of the nuclei, and they look like, how is it called? A horseshoe. Can you find this, this giant cell here, which is of Langhans type? Langhans type.
Maybe
Go down a bit, down, not so much. A bit right. Here it is. That one. Okay?
Is it one cell?
One cell. It's one cell with many nuclei. No, just a moment. We have to look at to study all the slides. So I have to be calm and with a nice temper. So don't talk to each other. It's not a time that you study the slides yourselves. You can do that during the weekend. That's the time where you study the slides. You get the links that you have in your documents. If there is any problem, you'll contact Mr. Petridis, Chris, there. If you cannot open the slides, you have a look at the video, at the MP4 file. You'll have a look at the slides and you'll come. That's all. So this is the Langhans cell, giant cell. It is indicative of tuberculosis, but under no circumstances is it typical for tuberculosis. No, it's more commonly encountered in tuberculosis, the Langhans cells giant, the Langhans type giant cell. All right, and the next one, thank you, yeah, and the next one is amyloidosis. That means deposition of amyloid, a substance, in the kidney. There is some sort here of atrophy in the tubules. However, I will not choose this slide. I'll choose the Congo red stain because this is the stain that highlights amyloid deposition. Deposition of amyloids starts under the endothelium. So we'll try to identify the structures of the kidney parenchyma that are affected by amyloidosis. So have a look. Have a look. Can you hypothesize what is stained with this Congo red stain? This is amyloid. So we see red stain here, you see, and red staining here. Can you identify this abnormal constituent of the renal parenchyma? To which normal constituent does it correspond? Which structure of the kidney looks like a ball? The glomerulus. So what do we see here? We see accumulation of amyloid in which part of the glomerulus? Previously, I said that amyloid starts being deposited under the endothelium. So what is the glomerulus? The glomerulus is the intracapillary it's an intraglomerular capillary network. So what do we have? Here is where the blood comes. Here is the endothelium of the intraglomerular capillaries, the basement membrane, and you remember the cell that is on the outer surface of the basement membrane of the podocytes. And that's how the blood comes and becomes urine. So, what's happening now? We have the deposition of amyloid under the endothelium. However, the basement membrane of the glomerulus is not full. That means it's not throughout the lumen. It communicates with the supportive tissue of the glomerulus, known as mesangium. So anything that is deposited on the inner surface, of the basement membranes, may come and accumulate in the mesangium. So where do we see the deposition of amyloid? In the mesangium of the glomeruli. And I explained you why it went there. Yes. So glomeruli are affected, and it's normal because they are composed of capillaries. And amyloid deposition starts from the endothelium. All right. What other structures are affected? Let's have a look here. Is this a glomerulus? No, it isn't. It has a lumen, one lumen, not many intraglomerular capillaries, one lumen, and you see, this is the glomerulus with mesangial amyloid deposition. So, what structure is this? Have a look. You see that its wall is red. What can this be? What can this structure be? Yes? It's a blood vessel of the interstitium. It is also affected because amyloid deposition starts under the endothelium, and here we see that the whole wall of this vessel is stained. All right. Now, let's have a look at these structures here. These ones. You see. Not the glomeruli with the amyloid, this structure here. What can this be? It has a lumen, and the lining is flattened because this is a microcystically dilated structure. What structure can this be? It has no amyloid deposition, however, it is damaged. What can this structure be? Who can tell me? Which part of the normal renal parenchyma can this be? Yes? Yes, it's a tubule. It could be either a proximal tubule, a distal tubule, or a collecting duct. I cannot tell why. I cannot tell because it has become atrophic. This is atrophy. And as you have learned from your respective lesson, which is the main factor that causes atrophy? Which is the main factor that causes atrophy to cells? Which? Yes? There's not enough blood. And can you explain that in the context of amyloidosis? It's very simple. All tubules, all urinary tubules, expect to get blood from what leaves the glomerulus. They do not have a separate way of blood supply. They have, you remember, this is the afferent and the efferent arteriole. So if the glomerulus no longer function because it has been destroyed by amyloidosis, there is no blood coming out of the glomerulus to give oxygen and blood supply to the tubules. But this does not happen abruptly, so we do not have an acute tubular damage, an acute tubular necrosis. It takes some time. It takes some time from the arterioles leaving the glomerulus to become narrow. So we do not have an acute tubular necrosis. we have atrophy. Yes, please.
Since here we are talking about a tubule, it wouldn't be coagular necrosis, even though it's the skin, it wouldn't have coagular necrosis, right?
The tubule, I think it would be coagulative. If there is some sort of abrupt obstruction of an artery, we have a pale infarct. That means coagulative necrosis. However, this is not the case here, because there is a gradual diminishment, a gradual decrease in the blood flow from the glomerulus to the tubules. So this is amyloidosis. Let me summarize. It's very easy. So here, let's have a look at another place. What are these structures affected by amyloid? What are they? The mesangium of glomeruli. Excellent. This one? Blood vessel. And what are these? These are atrophic tubules. And how can you tell that they are atrophic? They have become microcystically dilated, and their lining, their epithelial lining, is no longer visible. It has become flattened because it did not receive enough blood. Yes?
I know that for this case it's clear, but in another case, could also the atrophy of the tubules be caused by a renal stone?
If you have a renal stone someplace where the urine cannot leave, you have dilation. And
it's going to be different nature.
You have dilation, however, the end result is the same. They will become microcystically dilated and atrophic. This is the case of chronic pyelonephritis that we will discuss, hopefully, in the next semester. Okay? This is atrophy. That's all. Any other slides here? Any other slides? This is amyloidosis. I disregard the hematoxylin eosin. It's not a good stain. Let's have a look at the Congo red. We have amyloidosis of the heart and the liver. Let's see if we can understand something. We have so much amyloid deposition. What cells could these be here? Can you discriminate these cells? Can you discriminate these cells, identify these cells? They are somehow like dark dots with not enough cytoplasm, an accumulation of such cells. Can you identify these cells and tell me what they are? Yes, please. They are lymphocytes. We have some inflammatory cells. However, amyloidosis is not connected with inflammatory infiltrate. It does not cause inflammation in the tissue where amyloid is deposited. But I see them here, that's why I ask. So can I tell which tissue is this? Probably the liver, but where are the liver cells? With the trabeculae, I'm not sure. It is filled with amyloid. Here on, what can this be? Here, this is the liver. So that the other was the heart. You see these trabeculae of liver cells? Where didn't we say that amyloid starts being deposited under the endothelium? Which is the blood system here in the liver parenchyma? The sinusoids. So have a look how nicely the sinusoids are highlighted due to amyloid deposition. You see? And probably some of these cells that we have to do with the sinusoids are Kupffer cells. So this is hepatic amyloidosis. Congo red positive. And the other tissue is from the heart. However, the deposition of amyloid is so wide that we cannot find anything else than amyloid, I would say. Next one, inflammation. We have the lung. Can you please tell me what structure is this in the lung parenchyma? Can you describe the structure? Don't be too accurate what is in the lung. Just tell me from general histology. What structure is this? It has a lumen. It's a gland. That's right. That's the correct answer. This is a glandular structure because it has a lumen and well-formed lining looking at the lumen, epithelial lining. This is cylindrical epithelium. And now, can you tell me what this glandular structure is called when it is encountered in the lung? Can you tell me? What glandular structures do we find in the lung parenchyma, in the lower respiratory system? What can this be? Remember from histology? Yes, please? The bronchus. This is a bronchus. Yes, and it is quite a big one. How can I tell that it is a big one? Have a look at this tissue surrounding the bronchus. This is the mucosa of the bronchus, the basement membrane, and have a look at these pink fibers around the lumen. What are these? What are these with this tissue? It's some sort of bundle, and these cells have enough cytoplasm. That's why they stay pink. They stay in the eosine because they need cytoplasm, because what do? They contract. So what cells are they? And when we see these cells in a bronchus wall, we understand that it is of an adequate size. It's not a terminal bronchiolus or a respiratory bronchiolus. It is some bronchiolus that has, what is this tissue around this specific bronchiole? Yes? Smooth muscle tissue. Yes, this is the tissue that when it is contracted in asthma, it narrows the lumen of the bronchus, and we have wheezing of the air passing through a narrowed bronchus. But that's not for today. So this is a bronchiole, quite a big one. Is it affected by inflammation? Do we see inflammatory cells in relation with the bronchus? No. It's relatively clear. It's relatively clear. Where is the inflammation? The inflammation is nearby. Where? What are these structures here being filled with the inflammatory exudate? What are these structures? And what would these structures contain under normal circumstances? And because here we have pathology, we have a disease, that these structures are filled with inflammatory exudate instead of air. So these are the alveoli. They do not have air. What has happened? We had streptococcus of pneumonia entering the lung. It secretes toxins. It causes damage. So this stimulates the inflammatory process. We have increased flow of blood in the area. That's why we'll find the microvasculature of the region. That means the capillaries in the intra-alveolar septae, and they will be congested because due to the secretion of the vasoactive amines, histamine mainly, we have an increased flow of blood to the damaged area. So let's have a look at the congestion. Here it is. You see how many red blood cells are evident in these septae. This is how inflammation begins. And which is the next step of inflammation, as we have discussed in our lessons? It's the margination of the white blood cells and their transendothelial migration to what is nearby, the vasculature, the microvasculature. And here, when the white blood cells leave the lumen of the capillaries, where do they enter? They enter in the alveoli, and so this is lobar pneumonia, because all alveoli communicate with each other, so the alveoli of a whole lobe of the lung have been filled with the inflammatory infiltrate. And this part of the lung does not function. So the patient will have dyspnea. He needs air. This part cannot have air because instead of air, there is the inflammatory infiltrate of pneumonia in the air spaces. So he'll have dyspnea, and if this situation persists, you'll have the blood vessel counts of the pressure of oxygen and carbon dioxide, and you'll see the respiratory failure because the blood cannot receive oxygen any longer. Why? Because there is no air in a significant part of the lung parenchyma. Now, let's identify the constituents of the inflammatory infiltrate. Who wants to come with me? Come, please. Come with me. Yes, please come and sit here, and we'll find them together because we have the interactive way. Yes. Not the monologue. No. So, what's your name? Nikos. Come, sit, Nikos. Now have a look here. Remember how the neutrophils looked in previous slides? The neutrophils are cells with lobulated nuclei. Try and identify the neutrophils if you find them now, because I feel you are somehow tired. If you find them now, it won't be necessary to come on Monday. You'll get the exam now because you are a bit bored from the whole thing, I am afraid. So I won't bring you on Monday, no problem. You'll do the exam today. Does everybody agree that Nikos takes the exam today and don't become too tired for Monday? Yes. So I say, why if you agree, no. This is the land of democracy, as you know. So I decide. So find anything? Want some coffee? I want to order you, and you got one. You have to make it stronger. No, not like the one I take, of course, not that thing. No, of course not. A bit, somehow. So try and find some. It's easy. The ones that the nuclei is not round, but it has some sort of lobulation. Maybe. So with the mice?
This, maybe.
Right. And this one, you see, it's not, this one is round. You see here, this one? This one is round. This one isn't now round. So this is neutrophil. This is a neutrophil. This one? This one?
Round.
This is a mononuclear cell. Probably a macrophage. However, I do not see. This is a macrophage. You see that it has the cytoplasm because it's phagocytosis. Oh. So these cells, when they are in the blood vessels, they are white blood cells. If they come out of the blood vessels, they are inflammatory cells. What do the neutrophils do? They destroy the microbe, the bacterium. What do the macrophages do? They come and phagocytose all the remnants in the site of the inflammation. And in this case, if all inflammatory cells work properly, the tissue will become as it were before the stressful stimulus. This will be the lysis of inflammation. Which is the prerequisite for the lysis of inflammation? No architectural destructure of the tissue. Because if we have architectural destructure of the tissue, then it won't be possible for the inflammation to be lysed. It will have healing. The healing process will start, and we'll see that. Any questions here? Yes?
This is going to lead to metaplasia and dysplasia?
No, not necessarily. No, it's rather irrelevant. Rather irrelevant. So, however, Nico, I see here there are a part of the exudate that it is not cellular. These are the inflammatory cells. We have described them. What can this be? You see here? This is a non-cellular constituent of the exudase. You see all these strands here? So what can this be? Do you remember that we have discussed the cases of inflammation? What can these strands be in an exudate? These are not cells. These are amorphous constituents of the exudates. What can they be? They look like fibers. However, it's not collagen because it is part of the exudate. It's not in the connective tissue. It's part of the inflammatory exudate. This is fibrin. Fibrin. What is fibrin? We have fibrinogen, which circulates in the blood, and when we have activation of the endothelial cells due to the chemical mediators, they form gaps. The endothelial cells in the vessel lumen form gaps, and fibrogen leaves the vessels and enters the interstitium and is polymerized, and we find this as fibrin. So, what is there for you to identify in an inflamed alveoli? You have the neutrophils, the macrophage, and fibrin. Okay? 3 things.
There's a question.
There's a question there. I have to. Yes, please. If we have an increased number of neutrophils, we might call that a microabscess. However, this is in a pre-existing cavity. The abscess forms a cavity on its own. It's not an accumulation of neutrophils in something that pre-existed. But you would say that such an inflammation would be suppurative inflammation because the collection of neutrophils is called pus. And by the way, have a look here. Have a look here. We leave the inflamed alveoli, and we have this area. Tell me, Nico, do you identify any parts of the lung parenchyma here? Are there any septa? Are there any alveoli? Are there any viable inflammatory cells? Here, no. So what do we see here? You have a tissue that it is amorphous, and it is stained. Which stain does it take, this tissue? Which stain is this? Which stain is this? We have 2 stains. One is hematoxylin, is the dark one, and the other is eosin, the oxyphilic is the light one, the pink one. Which stains that? Eosin. It's eosin. And what does eosin stain? Eosin stains the cytoplasm, necrosis, and the fibrous tissue, collagen. These are stained by eosin. What can this be? And you see here this dust. You see this small. You are, of course, you know.
You just did it.
Yes, you did it, but you understood that because you were eager to understand it. If you are not eager, anything I do is hopeless. If you deny, that's the problem. If you are negative to the process, there's nothing I can do. Okay. You want to come on Monday? You want? You are too cool, I see. No. So everybody who is anxious and has problems with anxiety will be friend of Nikos here, and everything will be settled. It will be settled. All right? Okay. Bye. So we have an area of necrosis. This is liquefactive necrosis. So how did this happen? The bacterium attracted many neutrophils. Some of them were destroyed from the toxins of the bacterium, and their hydrolytic enzymes left the cell, and they caused liquefactive necrosis. The clinical term for liquefactive necrosis that we see here is pus. Pus. And if pus is formed in some parts of the body, three things may happen. It either fills a pre-existing cavity, and this is called an embyema. It forms a cavity, like here, filled with pus, and this is an abscess. Not a microabscess. Microabscess is a microscopic term. This is a cavity filled with pus. So it's an abscess. What else can it do? If it destroys a lining covering epithelium, this is ulceration. And if it makes a way through the tissue so that it goes to a free cavity to fill, for example, here it crosses the lung and goes to the pleura. This is fistula. Okay, fistula formation. These are the three consequences of pus formation. So what do we have here? We have a cavity in a pre-existing, in a non-pre-existing cavity. That means that the pus formed the cavity itself. And we have the liquefactive necrosis. Here we have a zone of viable neutrophils. See the neutrophils? Why do I say that they are viable? Because I can see their nuclei. You see? And then we have tissue here, scar tissue, that shapes the whole accumulation as an abscess. What is an abscess? A cyst filled with pus. And how does the tissue help me to treat the patient now that he has an organized abscess? What is there for me to do? I give antibiotics, but no matter how I give the antibiotics, either peros or injected, they'll reach the area with circulation, with blood. Where are the blood vessels here? Are they in the center of the abscess where the microbes were? No, they are on the outer zone. Can you show me? Show me a vessel there in the outer zone of the abscess. Because that's the point where the drug will reach. It cannot reach the microbes. The microbes are in the center of the abscess. That's right. Try the mouse. It's easier. Try the mouse.
Here, for example, is a vessel.
Okay, you have +5. +5 you get. Okay. You see? That's where the drug comes. Where are the microbes? Down here. So, the drug cannot reach the microbes and destroy them. What is the solution then? In a well-formed, in an organized abscess, what do you think? How does the tissue help you to find the right way to treat this problem? What will you do? Yes, please? Who can tell me? If you'll have, yes, it's surgery. The solution is surgical. We said that inflammations are not primarily treated by surgery because we have conservative ways. However, if we have complications, there may be no other way than surgery. So you open the abscess and take the pus away. And of course, if this is an area where you can reach easily, or that you don't have to open the patient. However, if it is in the central neural system, if it is in the lung, you may have surgery. Next complication of this lobular pneumonia. Have a look at these alveoli. This one here, by comparison to these ones. What tissue seems to have developed, and what does it cause to these alveoli on the left. Evaluate them. Look at their size, at their configuration. What do you think has happened here? Yes, please. Excellent. They are somehow strangled by newly formed scar tissue. Who caused this? The macrophages, because they secrete the fibrogenetic factors, mainly transforming growth factor beta. So now that we have scar formation, that means desmoplastic reaction, and finally the cellular component is diminished and we have just collagen, that means scar. So what does this mean for the duration of the inflammatory process? What does desmoplastic reaction and scarring tell us about the duration of the inflammation? It's been chronic. This is chronic inflammation. So fibrous deposition, fibrous tissue deposition, scarring, desmoplastic reaction, all these terms are similar, are hallmarks of chronicity. Chronic inflammation has this. And here we have a complication of pneumonia that a significant part of the lung parenchyma is replaced by fibrous tissue. Okay. And why did all this went wrong in this patient? Let's have a look. Perhaps the tissue can help me and decide what medication will be suitable for this patient. Are there any peculiar cells here? Who can come and show me the cells? Right there from the outer part. Can you come? Can you come here and show me the cells? No, not you. The corner. Come here, please. Yeah, come. It's easy. No worry. Because there are some cells here that we identify in the tissue and they tell us what to give to the patient. Sit, please. What's your name? Edmund. All right. So, are there any cells, Edmund, here that you would like me to describe? What do you think? Ah, okay. Yes. Which cells do you think that need some sort of explanation? It's very nice where you are.
These ones.
Excellent. Show them with the mouse. Great. So there are some big cells with some strange nuclei. And have a look, Edmund, here, what they have. This is an inclusion. You see this? This being white here, some sort of clearing in the nucleus. What does this notify? There is a virus that entered these cells. Most probably, they are pneumonocytes. And a virus entered in the cells, and that's why they have become big, and they have these nuclear inclusions. Nuclear inclusions. And this virus is cytomegalovirus. You see the clearing here of the nucleus? Yeah. Here are the septa of the alveoli, some parts, some inflammatory infiltrate with fibrin and inflammatory cells, and we have the inclusions, the CMV inclusions. Now, do you think we have here a stressful stimulus? We have an infectious agent. Do you think that this is the cause of the pneumonia, which that we previously saw does not fit a viral pneumonia? Which of the features that we have seen previously is not compatible with a viral pathogenesis of pneumonia? No, that could be. Chronicity could be. Another thing that we saw, that it is not compatible with virus inflammation, but of bacterial inflammation. Remember what we saw? The pus, the abscess. If we have the abscess, Edmund, it's a bacterium. However, we have an additional infectious factor here identified histologically. Do you think, is there a way for me to find if this infection, CMV infection, is active or chronic? Can I look something in the blood and see that the infection is recent? So I have to take it into account in what drugs I'll give to the patient. Or if it is a chronic, an old infection, which do you think what shall we look for in the blood? Yes, please? Yes, we'll see the immunoglobulins. So, which immunoglobulins are against the cytomegalovirus are of a recent infection, IgM class, and if we have IgG, it's an old infection. But if we have gradually increasing titers of IgG, then we'll have an old infection that has become active. So, in any case, since that we have an additional inflammatory factor, yes, what does this tell us about the immunocompetency, about the immune system of the patient? What do you think, Edmund?
Compromised.
It's compromised. So he might have HIV infection, he might have had a transplant, so I give the immunocompression so that he does not reject the transplant. So a patient has become immunocompromised, as Edmund says. So we have an additional infection. These infections are called opportunistic infections, yes. All right? Thank you. So that was the slide of lobar pneumonia.
Professor?
Yes, please.
Before the pus formation and the scar formation.
First we have the pus and then the scar. Scar is later.
Okay. So we didn't have a necrosis before the pus.
It's not necessary for a necrotic area to become fibrotic. Fibrous tissue is depositive irrespective of the presence of necrosis when the inflammation reaches chronicity. Of course, a necrotic area can become fibrotic, such as we saw in the myocardial infarction. Remember we saw the scar there?
Sir,
Yes, please.
it is too clinical, but why did you tell us before that you would choose to do an immunoglobulin test and not just...
It's all, when you have an infectious agent, you have to look.
Why not just CRP, for example?
What not? This is a general marker. Because this could be related to the bacterium infection. The bacterium infection is present. You want to see if the viral infection is also active or if it is not. That's why you look at the immunoglobulins. It's the same thing that you have in a pregnant woman. You have the antibodies for many infectious agents. If they are IgG, they won't hurt the embryo, the baby. If they are IgM, there's a problem. Here we have the appendix. Now, this is the let me have a look at the normal mucosa of the appendix. However, I cannot. No, just a moment. Just. Everybody who is tired, there's no problem. We have no presence taking here, no taking presence. He can leave and just watch the video. But everybody who sits here must be very, very silent because I have to cover all the slides till 3 o'clock. 3 o'clock, we leave. So there is no time for delay. We have to look all the slides carefully, record them, and you can study them during the weekend, practice with the virtual slides from your e-class, from your portfolio, and that will be all. So, what do we see here? This is the only area that we have some sort of mucosal epithelium. All the rest has been damaged. The mucosa has been damaged due to inflammation because this is acute appendicitis. So we have formation of granulation tissue. So what do we see here? Thin-walled vessels with mixed inflammatory cells. What is this inflammatory cell? Neutrophil. Because we have acute appendicitis. These are the thin-walled vessels of the granulation tissue, which means that the inflammatory exudate is being organized. This is the granulation tissue. However, this granulation tissue has replaced the covering epithelium, the glandular epithelium of the area of this part of the large bowel. When we have an inflammation destroying a covering epithelium and not being just an erosion, but we have the granular inflammatory tissue formation underneath, this is called N. We have pus filled with neutrophils, viable and non-viable, and it destroys the mucosal lining and it replaces it with granulation tissue, like here. What is this called? This is called an what? Ulcer. An ulcer, yes. Excellent. This is called an ulcer. So this is ulcerative inflammation. What is an ulcer? Destruction of a covering epithelium, either the skin covering epithelium, squamous, either the esophagus, squamous epithelium, either the stomach, glandular epithelium, the duodenum, the large bowel, and replacement with granulation tissue. This is called an ulcer. And let me have a look at the inflammatory cells. Look where they have reached. Which part of the appendiceal wall is here? You see the neutrophils? See the neutrophils? Which tissue have they reached? Which tissue have they reached here? Which? What? This is fat tissue. And where does the wall of the bowel has fat tissue? Subserosal. Subserosal. So, when we have the inflammatory infiltrate going thus down throughout the bowel, and if it erodes the serosa, what is the serosa? It's the one layer of the peritoneum covering the organs of the bowel. If it breaks the serosa, where will the inflammatory exudate be spilled? Throughout the peritoneal cavity, and will have the complication of acute peritonitis. That's why when we have acute appendicitis, and how will we understand that? We have fever, pain here where the appendix is, and when you press, the pain becomes stronger. This is sensibility, because how is pain caused? It's due to the exudation of the inflammation, because the nerves causing pain are triggered by the increase of tissue contents due to the exudation of the inflammatory exudate, and we have the specific chemokines triggering the sense of these nerves and causing pain. So, and what else? How else will you become sure that this is acute appendicitis? Apart from the clinical evaluation, what will you ask for? You have? Yes, please. There? Not first. If you can ask that, the ultrasound, but first the most easy thing to find is what? Not immunoglobulins. You'll have the general examination of the blood, because what will you find? Leukocytosis with neutrophilic type. That means you'll have an increased amount of leukocytes in the blood with a neutrophilic predominance. And this is consistent, taking into account the other symptoms with acute inflammation of bacterial origin. So this is direct extension of the inflammatory infiltrate to the tissues. Yes, please.
Can you just repeat the granulation part?
The granulation tissue. Granulation tissue is formed when the inflammatory exudate cannot leave. It stays there, and due to the presence of macrophage, granulation tissue develops. What is granulation tissue composed of? It has a mixed inflammatory infiltrate, meaning neutrophils, and macrophage, mononuclear phagocytes, thin wall vessels that break very easily, that's why it becomes hemorrhagic, and fibroblasts, which gradually predominate and they form the scar. This is the natural history of granulation tissue. Yes. Our next slide is cholecystitis. Have a look here. Again, we have an ulcer in the mucosa. This is the only area where epithelium is evident. What cells are here predominant? Can you identify these cells? If there is somebody that cannot identify these cells, now that we have shown them about 20 times, he'll call me and he'll tell me where his home is, and I'll come during the weekend. I'll come and have an extra lesson. What cells are these? You know them. Neutrophils, of course. So this is acute cholecystitis. Too many neutrophils, I'd say. A pass. And what? Let's have a look here. The neutrophils, here they are. And let me see where the granulation tissue is formed. You see? You see these thin-walled vessels that break so easily and cause hemorrhage. These are the newly formed blood vessels of the granulation tissue. So we have acute inflammation here. However, we see that the wall of the gallbladder is greatly thickened due to the accumulation of these cells. Can you identify these cells? They are fibroblasts, which deposit collagen. And we'll find the collagen deposition. However, I want you to pay attention to this cell. Does it have a lobulated nucleus? Is it a neutrophil? No. The cytoplasm is too red. This is eosinophilic. Eosinophils are polymononuclear cells which are encountered in chronic inflammations, parasitic inflammations, and allergies. So, this is not a sign of acute inflammation. This is an eosinophil. Okay. And let's see at the collagen deposited here and causing all this thickening of the wall. Here it is. These are the collagen fibers. You see? These fibers are deposited by these cells, fibroblasts. Yes, but as I previously said, what signs of inflammation is this? Desmoplastic reaction and collagen deposition. Chronic. So what do we have? Chronic and active. This is chronic cholecystitis because we have all this thickening of the wall due to collagen deposition and fibroblastic reaction. However, don't forget all those neutrophils we found on the surface. So it's chronic cholecystitis but in an active phase. So it's interesting why the patient had surgery, because all surgeons prefer to remove organs that do not inflame, that do not have acute inflammation, because due to the surgery, perhaps the inflammatory can go to the peritoneal cavity and cause a complication. However, if a very serious and dangerous complication is imminent, that meaning that the whole gallbladder is filled with pus and may break, it's necessary to perform surgery in such a time point. Next one. This is an inflammation taking place here under the skin. You see the squamous epithelium? And here are sebaceous glands, follicles, hair follicles, and eccrine glands, sweat glands. Now, how do you understand the inflammatory area? There are many, many dots, because that's how inflammatory cells look. They do not have generally enough cytoplasm. And who can show me where the inflammatory area is in this field? Yes, come please. Where are the inflammatory cells? And I want you to show me their configuration somehow. Yes, please. What's your name?
My name is Fotis.
Fotis. So where are the inflammatory cells? Here they are. But I want a lower magnification and see. I'll try to find if they are dispersed like all the previous inflammations we've seen, or are they somehow gathered?
They are somehow gathered.
They are somehow gathered. So that's what you show me. This is a nodular configuration of inflammatory cells. And here is another nodule as well, a smaller one. Excellent. When we have inflammatory cells with a nodular configuration, if they are B lymphocytes, it's a, how is it called? Lymph nodule, lymphoid follicles. If we have lymphocytes forming a nodule. If we have other inflammatory cells, this is called a granuloma. So what are granulomas? Granulomas are nodular aggregates of inflammatory cells. Not B lymphocytes. In that case, they are called lymphoid follicles. Okay?
The caseous, no.
No. In that case, we had granulomas, immune granulomas, and some of them had caseous necrosis. This is what was compatible with tuberculosis.
It's specific for
But tuberculosis, this is a specific inflammation. What we have here is, no, slow, because I have to finish, because if I do not finish at 3 o'clock, then I'll have to come at everybody's house and have the extra slides shown. And I'll have quite a long way to, you live here, you live here. Traffic, of course. So be patient, because I want to finish in 25 minutes. And there is not enough time for many questions. But I cannot, if we have questions, I must get the questions. So tell me, please. No, sorry. The lymphoid follicles are in a lymph node, which may make a lymphoma if it becomes malignant. No. They are normal constituents of a normal lymph node. They are called lymphoid follicles, B cells. In the lymph node cortex. Yes, please.
The part about the granuloma, you said if it was a B cell or...
If a granuloma is solely composed of B lymphocytes, it is not called a granuloma, it is called a lymphoid follicle. All right? And it can for a lymphoma, but it's not for today. So, no, sit down, folks. We have the inflammatory cells. So tell me, is this, what cell is this? What inflammatory cell is this?
Neutrophil.
Neutrophil. Is it an inflammatory cell? Yes. You say yes, but since it is in the blood, you see it's in the lumen. So it is a white blood cell. It has not yet become an inflammatory cell, because if you see the same cell in the inflammatory exudate, you'll say it's an inflammatory cell. The cell is the same, but if you see it in the lumen, of the vessel, you see it's a white blood cell.
They don't express other markers or
No, no, it's the same cells, the same cells. Next, have a look at this one.
macrophage.
Excellent. You see how bubbly the cytoplasm is? But this is another... No, because, because it is a mononuclear cells. We'll see. You see, this is a mononuclear cell which has a different kind of cytoplasm than the macrophage. Okay? It's somehow amphiphilic, and the nucleus is in this part of the cell, and this cell is responsible for immunoglobulin secretion. This is the cell of chronic inflammation. What is this cell? Plasmacyte. This is the plasmacyte. So have a look at these plasmacytes, this one.
But you just know information and you came to a conclusion. You don't see it, right? You cannot see and distinguish.
Sometimes you can see the immunoglobulin. It is deposited in the tissue, but it's not always the case.
You cannot tell it's a T cell or a B cell. You just know the context.
If you see the plasmacyte, you know that it is a B cell, because B cells secrete immunoglobulin. If you see a small lymphocyte like this one with minimal cytoplasm, you cannot tell. Is it a B cell, a mature lymphocyte, a B, or a T? You cannot tell. So, and what happened? You have some multinucleated giant cells like these.
These are fused macrophages.
So, just a moment now. I want you to be very careful so that I'll have time and show you the basic features of each of the remaining slides. There is no time for other remarks, and I have to leave at 3 o'clock. I have to leave. Okay? So, if somebody cannot be careful, he can leave, and it's okay. He can watch the video. All right? So, these are the multinucleated giant cells. And this is, no, it's not lung cancer because they are somehow mixed. The nuclei are mixed here, Photos. So it's a foreign body type giant cell. And where is the foreign body? Here it is. This is the foreign body. What is this? This is keratin from a hair follicle that the squamous epithelium of the follicle has broken, and a normal constituent of the body has entered a wrong place. So it is recognized as a foreign body and causes a phagocytic inflammatory reaction in the form of a granuloma, a foreign body type granuloma.
Like when we get shaved and the hair goes inside.
It's exactly the same mechanism. That's right. So these are foreign body granulomas, which are quite different from the immune granulomas we found in the lymph node, because in immune granulomas, they are nodular in contour. However, they have a specific type of cell known as the epithelioid histiocyte. This means specific inflammation, immune-mediated inflammation. So, next one. We'll have the epithelial neoplasms. Have a look here. This is the metaplasia, yes. So, we have the lining epithelium of the cervix, multi-layered. However, you see the basal cells here, and the upper layers, which are more mature. How do we understand that? They have more cytoplasm. As the cell matures, it acquires a considerable amount of cytoplasm. However, in the basal zone, it appears dark because it is immature, because this is the proliferation zone. All this is normal. If you see glandular tissue here, beneath. You see the glandular structures? This is glandular epithelium. And this is squamous epithelium. The epithelium should be the same, because what you see in the lamina propria communicates with the surface. You cannot always see the communication because you see it in 2 dimensions, not in 3. So one of them is metaplastic. The one up, the covering epithelium, is squamous metaplasia. Why? Because what you see down is glandular, and what you see as a covering epithelium, you see it as a multilayered squamous epithelium. However, it is normal. That's why I call it metaplastic. This is not the case with this metaplastic epithelium. What's the difference here? You see that it does not mature. Immature cells, like the ones we had encountered only in the basal zone, now they occupy all the layers. And this is dysplasia, high-grade dysplasia, if it enters all the thickness of the squamous epithelium. And have a look here. 1, 2, 3, 4. How many mitoses are, you see, visible? Because as a sign of malignancy, it has increased tendency for proliferation. Which mitosis is more compatible with malignancy? This one down here, or this one up here?
The one up.
Of course, because that's the place where cells should be mature and not dividing. In the basal zone, it is expected to find some mitotic activity. However, in dysplastic epithelium, we have mitosis in places where we should not have them. All right. So this is dysplasia and high-grade dysplasia because the whole thickness of the epithelium has been replaced.
Metaplasia is physiologic?
Yes, it's almost physiologic because the new epithelium is mature. But this one, in addition to being metaplastic, is also dysplastic because it has loss of polarity, loss of maturation. However, it is not cancer. Why isn't it cancer? Because there is no invasion. You see that the basement membrane here, the basement membrane remains intact. So that was dysplasia. Let's have a look here. Now we have skin, that we have keratinized epithelium. You see the keratin? However, we have some downward proliferation of irregularly shaped cells. And have a look, Fotis, where they enter. What tissue is this? You see that this tissue here is being invaded by these cells. This must be muscle tissue, some sort down the lamina propria of the skin, the dermis, okay? So we have invasion. You see all these cells here? You see how without any order they go here and there? This is one hallmark of malignancy. This is invasion. The other is nuclear pleomorphism, because we have prominent nucleoli here, you see? And we have a variation in the size and shape of nuclei. This is called pleomorphism. So we have evidence of nuclear atypia and invasion. This is compatible with malignancy, malignant neoplasm. What do we do next? We look for differentiation. What is differentiation? The malignant cells, do they have something that look like something normal? Have a look at this follicular material that they produce in quite an extensive area. What substance is this produced by malignant cells? It's similar to this. That was keratin of the normal squamous epithelium. This is keratin follicles, follicular, you see the follicles? This is keratin produced by malignant cells. So this is evidence of squamous differentiation. All right? Since squamous cells are epithelial cells, how do we name the malignant neoplasm of epithelial cells? Carcinoma. And since we have squamous cell differentiation, this is a squamous cell carcinoma. And since the malignant cells are widely keratinized, it is of low grade. Of low grade. That means it looks like normal, however, it is malignant. This is grade 1, low grade or high differentiation. That means it has signs of maturity despite being invasive and malignant. So this is a well-differentiated squamous cell carcinoma. However, in this area, we have no keratinization. Only individual malignant cells are keratinized. Keratinization is a process of apoptosis. So when we have keratinization in single cells, this is called dyskeratosis. It is evidence of keratinization. However, this is evidence of high grade. That means low differentiation. Grade 3. So poorly differentiated. That means we cannot easily tell the tissue of differentiation. And in other cases, we had to look for intercellular bridges among malignant cells. So, the good news are that since we did not have enough time due to you talking all the time, you won't have all the slides for Monday. For exam, you'll just have dysplasia, squamous cell carcinoma of the skin, and we'll have the adenocarcinoma of the lung. Only three slides from epithelial neoplasms for Monday. Cervical dysplasia, squamous cell carcinoma, the one we just saw, and the next, that will be our last slide for today, adenocarcinoma of the lung. So let's have a look at the adenocarcinoma of the lung. Here it is. Adenocarcinoma of lung. So, pay attention, please. So, what do we see here? What part of the lung parenchyma is this? Alveoli. Yes, these are somehow in shape, looking like alveoli. However, they are lined by atypical cells. So these are cancerous cells. What is the significance of this so-called lipidic growth of an adenocarcinoma? If you see malignant cells lining normal-shaped airways of the lung, it is most probable that the carcinoma is primary in the lung. and it has not come as a distant metastasis from some other site. So if you see alveoli being lined by atypical cells, this is compatible, consistent with primary cancer of the lung. If you see malignant glandular structures like this, which do not look like alveoli, you are never sure that the adenocarcinoma is primary, because taking the patient's history into account, this could be the end stage, the metastasis, the hematogenous metastasis from any other adenocarcinoma arising in the pancreas, in the colon, in the endometrium. So, in such case, you have to communicate with the clinician, is there a history of previous cancer? Because in that case, it's no use of staging the adenocarcinoma. You know the stage. It's the end stage of the previous cancer the patient had. So, this is what staging is about. However, we must decide the grade of the tumor. In this, have a look at this part of the adenocarcinoma. We see malignant infiltrating glands, which, however, are separate from each other. They are somehow well-formed glands. Oh, so which grade would you assess here? That we have malignant glandular structures invading here, there. However, they are well-formed. We can easily understand that it's glandular epithelium, the malignant one. This is low grade, yes. This is high differentiation, low grade, grade 1 of adenocarcinoma. What is different in this structure? We can see glandular differentiation. Here are the lumen. However, the glands are not separate from each other. They form a cribriform structure. This is intermediate differentiation, grade 2. And here, can you tell that this is an adenocarcinoma? We have the malignant cells forming solid structures. If all the tumor was like this, we would never know if it were an adenocarcinoma. So we would have to have immunohistochemical staining and see, is it napsin A positive? Yes, so it's an adenocarcinoma. Napsin A and TTF1. Immunomarkers. Is it P40 positive? Yes, so it is a squamous carcinoma. What does this mean? If a carcinoma is high grade, we never know if it is in the present site as primary or metastatic, and we should look sometimes with extra stains, specific methods, to identify the derivation of these cells. So now that we have seen other areas that it was an adenocarcinoma, we can say that this is a high-grade component, a component of poor differentiation of the adenocarcinoma. And consistent with this high-grade area of the tumor is, you see, increased mitotic activity, increased apoptotic activity. Can you identify the apoptotic remnants? These two small dots are the apoptotic remnants. And what else can we say? What has happened here in the cancer? What area is this? It's inflammation, acute inflammation with neutrophils, and this tissue. What happened to the cancerous tissue in this area?
It died.
Necrotic. because this is a sign of increased biological aggressiveness. If a tumor becomes necrotic, it means that its neovascularization is not enough to give enough blood supply, so it becomes necrotic. Yes, but the necrosis should be somehow geographical. That means not throughout the tumor, because if you see a tumor that it is throughout necrotic, this might have to do with something irrelevant to the biology of the cells, something like an acute happening.
Do we call this nuclear debris again?
Yes, it's debris here. This is the debris, nuclear debris, nuclear dust.
Sir, also,
Yes.
necrosis partly for the site of the cancer, it may not be also beneficial for it.
No, it's not beneficial at all.
For the cancer.
No, it's not. It means that the cancer is so aggressive that it can spread everywhere,
All the neutrophils that will gather.
despite the fact that inflammatory cell gathers. However, these cells are not neutrophils. Which cells are they? There is 1 minute and 4 seconds left. Just a moment. Yes. Do they have cytoplasm? No. So they cannot be macrophages. They cannot be plasmacytes. What are they? They are the immune cells against cancerous tissue, lymphocytes. And which subsets of lymphocytes have T8 or natural killer cells are the main lymphocyte populations for destruction of cancer cells by the host organism. Okay? So have a nice weekend. See you on Monday. Me too.